So then she came to us because she wasn't really getting any of the answers that she really wanted. She was first seen in a neuro clinic November 5th, 2012, and we were able to tease out a little bit more of her symptoms. She noted that she saw a chronic vibration, mostly in the right eye, that was lasting only seconds, about 2 to 3 seconds at a time, but now she felt was getting worse, lasting longer in duration as well. She also notes that she has blurry vision when this happens, with symptoms that were very symptomatic and suspicious for oscillopsia. And these episodes appeared in blocks of activity at a time, and it was now worsening in duration, lasting 5 to 6 seconds rather than 2 to 3 seconds, and also increasing in amplitude. These are ocular vital signs. They're all fairly normal. And so I'd like to show this video. This isn't the patient in question, but has a lot of the same symptoms that we initially saw on exam. And so before I play this, I want you guys to focus on the right eye. And the images, the findings are a little bit subtle. So you'll note that over time, you'll see some fine torsional vertical movements in that right eye, right there. I'm just going to play it again. It's very subtle. Just some fine torsional vertical movements. Right there. So the diagnosis of this particular condition is really, there's only one thing in ophthalmology that really looks like this. And so it's basically superior oblique myokymia. So this was first described by Doyens back in the early 20th century as a unilateral rotary nystagmus. Patients usually report a history of periodic unilateral oscillopsia and some symptoms of binocular vertical diplopia. It's basically a sudden rhythmic monocular contraction of the superior oblique muscle, and it's best seen when the vision is directed downward and inward along the path of the muscle's action. There may be some subtle hypertropia and excyclotorsion evidence due to the action of the muscle, and it's very subtle, and it's best seen with mild and moderate magnification underneath the slit lamp. If you look at a particular landmark on the eye itself, like such as a vessel, and observe its torsional movements. The duration of these symptoms are usually a couple of seconds, although there's been cases lasting up to minutes at a time, and that can be very debilitating for the patient. And it's really important that you have a high index of suspicion for this particular condition, because oftentimes these patients can go asymptomatic for an extended period of time. And so if you guys aren't paying attention for it, you might never see it. Demographically, it typically occurs in young to middle-aged adults that are otherwise healthy, and it's about 50% male and 50% female. Now, interestingly, in female patients with this condition, the right eye is statistically more common to have this condition compared to the left eye, but there's no such relationship in males. The pathogenesis of the disease itself is that it arises from erratic axonal nerve impulses in the trochlear nerve. It can be spontaneous or following trauma to the fourth nerve with subsequent aberrant regeneration of the nerve. And it's also been shown that the course of the nerve itself passes closely to the superior cerebellar artery. So vascular compression can be an instigating factor in certain instances. There's also been cases reported in patients that were later found to have a posterior glioma. And so after resection, these symptoms can resolve. And so because based on these reports in the last 2 bullet points, we had the patient undergo an MRI, brain orbits with and without, that was negative. So let's talk a little bit about treatment options. It's often based on severity, and these patients, mild cases can be observed for the most part. If it becomes debilitating to the point where they need treatment, first-line treatment is oral or topical treatment. And carbamazepine is a popular choice, and it's used for its membrane stabilizing effects. And this report basically showed about an 80% success rate in a retrospective review for these patients. Other medications that use the membrane stabilizing effect include baclofen, phenytoin, memantine, and gabapentin. Oral and topical beta blockers have also been used with some success. Oral propranolol, 10 milligrams daily, is a popular choice by clinicians, as well as our standard timolol drops. In cases where oral and topical medications do not achieve the desired effect, the next step is often to consider surgery. And so strabismus surgery has been considered in cases refractory to medical treatments. This paper by Argawal et al. Describes a large superior oblique tenectomy along with a ipsilateral inferior oblique myectomy to help counterbalance the superior oblique underaction that occurs from the tenectomy itself. And so they reported a good success rate with this particular technique, but they also noted that up to a quarter of these patients ended up having a symptomatic hypertropia in down gaze that required additional surgery or prism glasses. And so this is something that you have to really caution the patient against if they're considering this type of treatment. A variation of the Hirado-Ito technique has also been used, basically splitting of the superior oblique and selective nasal transposition of the anterior fibers of the muscle. And in certain cases where vascular imaging shows signs of vascular compression, neurosurgical decompression procedures have been described and has been used with varying success. So this next case is from the Journal of Neurosurgery, looking at basically a case report of a patient undergoing such a procedure. So this guy was a truck driver who had been having worsening symptomatic diplopia and oscillopsia from the superior oblique myokymia, presents many different doctors, all could not give him a concrete diagnosis until one particular astute ophthalmologist observed it. He had tried oral medications, he had tried topical medications, he even had a short course of Botox to that muscle, and all of them failed to achieve the desired effect. And it was worsening to the point where he was actually considering disability because he could no longer do his job as a truck driver. And so this photo right here shows a lateral suboccipital approach for brain surgery, and the cerebellum is actually reflected down. And this white arrow here shows the trochlear nerve kind of coursing around the brainstem, around the cerebral peduncle. And further reflection from this point of view shows that this black arrow right here, this junction where the vascular compression was happening in relationship to the trochlear nerve. And so in this particular case, they went ahead and dissected the subarachnoid adhesions, cleared out that particular space, and placed a Teflon patch that was able to separate out the nerve from the vasculature itself and prevent this compression. And as of 22 months of follow-up, this patient had complete resolution of his symptoms of oscillopsia and was quite happy with the end result. Although the authors did mention that they had issues with some cranial nerve 4 palsy signs and some diplopia in extreme gaze, but that these symptoms did not bother the patient at all, and he was overall quite happy with the end result. So going back to our patient, we saw her next August 26, 2020. And so this was a little bit less than 8 years since the first time we saw her. She now presented because she was noticing worsening symptoms, particularly with binocular horizontal diplopia. And she felt like her eyes were now feeling that they were kind of twisting, having some torsion. They were kind of pulling out, and she was able to kind of re-engage when she focuses, but when she gets tired throughout the course of the day, she felt like she was getting sort of misaligned and her right eye was kind of pulling out and she wasn't able to control it. And these symptoms were exacerbated by down gaze. So again, her ocular vitals looked perfectly fine. The only thing was she did get some LASIK surgery during that time, and she was seeing a perfect 20/20. The pertinent exam finding that we found that was new was that she now had a left head tilt with a concomitant V pattern esotropia worsened at near gaze and a right hyper worse than left gaze. And so going through the Park's 3-step test, we know that a right hypertropia in primary gives us a right superior oblique, a right inferior rectus, a left superior rectus, and a left inferior oblique as the muscles that are in question. Worse than left gaze leaves us only with a right superior oblique and a left superior rectus. Compensating with a left head tilt nails the diagnosis of a right superior oblique palsy. So I just wanted to kind of go into the anatomy of the fourth nerve and the superior oblique. I know as a junior resident, going into neuro clinic or seeing an ED consult, the very mention of a binocular diplopia was more than enough to send shivers down my spine. And it was also made me very nervous on trying to kind of localize and figure out what exactly was going on. And so the superior oblique muscle, basically looking at the actions, the primary action is obviously intorsion, secondary action, depression, and adduction. Tertiary action is abduction. The fourth nerve is the longest and thinnest cranial nerve. Its nucleus is localized to the midbrain, and it's unique in that it exits dorsally first of all, and then crosses with itself right here posterior to the brainstem and goes around the cerebellar peduncle, goes through the lateral rectus along with the third, sixth, V1 and V2, and it enters the orbit via the superior orbital fissure, passes outside the ring of Zinn, which is a popular anatomic board question, and innervates the contralateral superior oblique muscle compared to the nucleus of origin. And so this has important implications when trying to localize this particular palsy. So when you see an isolated ipsilateral fourth nerve palsy, the things that you think about is that it's either post-traumatic, it's congenital, that further decompensates as the patient gets older, and that can be teased out by looking at the fusional amplitude. So patients that are congenital often have very large vertical fusional amplitudes compared to patients that develop fourth nerve palsies later on in life. Or it can be microvascular in nature. Now, if you have a bilateral fourth nerve palsy, they're usually post-traumatic, and they present often with an alternating hypertropia. So you will see a right hypertropia in left gaze and a left hypertropia in right gaze. There's often a significant torsional misalignment to these cases as well. And you can use that, you can figure that out with the double matrix rod. And so anything more than 10 degrees of torsional misalignment is suggestive of a bilateral fourth nerve palsy. Neuroimaging is not indicated in all these patients, but should certainly be performed in patients with a progressive fourth nerve or a presumed microvascular fourth nerve that does not recover within 3 months of initial diagnosis. So signs to kind of look out for and to help localize where these lesion is occurring is that lesions close to the trochlear nucleus can produce a ipsilateral Horner's and a contralateral fourth nerve palsy. And that's because, as we kind of previously mentioned, the fourth nerve crosses over, and it's also, the nucleus also in close proximity with the sympathetic chain. And so if you get a lesion in the nucleus, it can hit the sympathetic system, and also that nucleus affects the contralateral superior oblique. Presence of an ipsilateral cranial nerve palsy 3-6 can be suggestive of cavernous sinus, superior orbital fissure, or orbital apex syndrome, just because of the high value areas in those particular locations. A lot of cranial nerves kind of passes through in those locations. Now, if you see brainstem signs or intorsion of the hypertrophic eye, then you should keep in mind that this could be a skew deviation rather than a fourth. As we know, the primary action of the fourth is intorsion. And so if it's a palsy, you would expect extorsion rather than intorsion of that particular muscle. Presence of areflexia or ataxia suggests a Miller-Fisher syndrome. You gotta keep that in mind. It's a type of a version of Guillain-Barré's. Fluctuating signs, differences in PDs as you're measuring, different amounts of ptosis as you're measuring, different varying symptoms of diplopia per the patient. Gotta think myasthenia, can't miss myasthenia. Just go ahead and get yourself an anti-acetylcholine receptor antibody test. Presence of exophthalmos or lid retraction, think thyroid eye disease, can't miss those either. So going back to our patient, the final diagnosis of it was a diplopia due to fusion decompensation in the setting of a fourth nerve palsy in association with a right superior oblique myokymia. So we discussed treatment options with this patient. Options such as patching or prisms. She had just gotten LASIK, so she wasn't super keen on the idea of having to wear glasses. So we kind of tabled that topic. We also talked to her about referring her for strabismus surgery. But honestly, the deviation that we measured in clinic was really too small to really be operated on, so we passed on that option as well. We discussed starting her on low-dose gabapentin, propranolol, and Tegravol, but she was not super keen on getting started on oral medication as well. And so we finally settled on increasing her timolol regimen. Now, she had previously been on timolol in the past when we first saw her back in 2012, tried it a couple of times, didn't really work for her, so she had self-discontinued the medication. But we just had her basically increase the dosing of the timolol that she was taking. And finally, because she had this new cranial nerve 4 palsy, we had her undergo a new MRI just because she hadn't had imaging for a pretty long time. And so that's kind of where we leave this particular patient, but I wanted to leave you guys with a couple of final thoughts when you guys see these types of patients. So superior oblique myokymia should be in the differential anytime patients present with a history of episodic vertical diplopia and oscillopsia. And it's not uncommon for these patients to see more than one provider, get bounced around multiple providers from multiple different professions, neurology, general practice, ophthalmology, optometry, before the final diagnosis is made. It's often associated with a cranial nerve 4 palsy, and treatment consists primarily of topical or oral medications with strabismus surgery as second line. Neurosurgery can be considered in patients where head imaging shows that there may be evidence of vascular compression of the trochlear nerve. And finally, it's really, really important to kind of tease out what exactly is bothering these patients, whether it's oscillopsia or the diplopia. Because if it's the oscillopsia, then you would probably consider more towards the oral medications, topical medication standpoint. Diplopia, you would consider more of the patching, prisms, and you would have to kind of take in mind that if you consider strabismus surgery for these patients, if these patients are having diplopia as sort of like the primary presenting symptom, further strabismus surgery can cause these symptoms to worsen. And so you definitely want to talk to these patients about this particular side effect. So that's the end of my talk. I'd like to go ahead and thank you, everybody on my neuroop rotation. Dr. Newman, Dr. Paragallo, who graciously provided the video, Dr. Buse, Dr. Datillo, Wes, Lexi, and Ben, who were tremendous help on the rotation.